Hello to everybody tuned in today. I am Dr. Judy Guzman from Oregon Health and Science University in Portland. And on behalf of SHEA, the Society for Healthcare Epidemiology of America, I would like to welcome all of you to today's webinar. I also wanted to briefly provide you with an intro to the SHEA CDC ORTP. This past summer, the Centers for Disease Control and Prevention contracted with SHEA to create a new training program called the SHEA CDC Outbreak Response Training Program, or ORTP. The ORTP's goal is to train hospital epidemiologists to effectively respond to infectious disease outbreaks and public health emergencies. This has been a massive SHEA volunteer effort. We have over 40 SHEA member volunteers divided into 3 panels: the advisory panel, panel, and expert guidance panel. I myself serve as the chair of the SHEA ORTP advisory panel. Over the next 2 years, you'll be hearing about many exciting new training opportunities, including 2 in-person outbreak response training workshops, a variety of web-based training opportunities, and our expert guidance panel has been very busy writing a concise, evidence-based preparedness and response document, which should be released later this year. If you'd like to see more details about any of the ORTP elements, including the dates of all of the upcoming webinars and in-person training programs, please go to SHEA's website at www.shea-online.org. And without further delay, I am now thrilled to kick off our ORTP training program with the first of 3 effective communication webinars. Dr. Yoko Furuya will be discussing communication during a crisis, what a hospital epidemiologist needs to know. Dr. Furuya is an associate professor of medicine at Columbia University Medical Center in the Division of Infectious Diseases and has been a hospital epidemiologist for almost 12 years. She serves as medical director of infection prevention and control and director of antibiotic stewardship for all New York Presbyterian hospital campuses. Dr. Furuya's clinical research focuses on healthcare epidemiology and antimicrobial resistance. Dr. Furuya completed her infectious diseases fellowship at Columbia University and earned a master's degree in epidemiology from Columbia's Mailman School of Public Health. And now I'll turn it over to Dr. Furuya.
Thank you, Judy, and good afternoon to everyone. Like many of you probably, I learned crisis communication and handling EIDs, or emerging infectious diseases, on the job, especially during the Ebola crisis. And I'm going to say up front that I think there are probably limits to how much you can learn about crisis communication in a lecture format, because obviously nothing can really replace living through a crisis and learning by doing. But today I'm going to share with you some basic principles that can help frame this for you, as well as some of my personal lessons learned and the mistakes I've made that hopefully you can all learn from. And there are also particular challenges with crisis communication at large medical centers, especially multi-hospital systems like mine. So I'll talk about some of the things we've done at my institution as well. So these are some of the things I hope you take away from this talk. To know the 6 core principles of CERC, which is CDC's Crisis and Emergency Risk Communication Framework, to have an idea of how to develop crisis communication plans for your institution, and to be able to start preparing ahead of an emerging infectious disease by creating effective crisis communication templates and messages. And finally, to understand how effective communication plans must be tailored to the intended audience. So I'll start by talking about why crisis communication is important to a hospital epidemiologist. And I assume I'll be preaching to the choir here, given the number of people who have chosen to call into this webinar. But then I'll spend most of the time talking about the CDC CERC framework, including the 6 core principles of crisis communication, as well as the phases of the CERC life cycle. And sprinkled throughout, I'll be using Ebola as a case study to illustrate what to do and what not to do, rooted in what I personally and we as a country did well and maybe not so well during Ebola. So over over the past decade and a half, it seems like the number as well as the magnitude of emerging infectious diseases, or EIDs, have been rapidly increasing. So rather than reinventing the wheel with each EID, we now know that we really need a standardized approach. And that holds true not just for preparedness in general, but also for crisis communication. And I think this is a lesson that the larger emergency management world already knew, and we in the infectious disease and hospital epi world are now starting to embrace that approach as well. So this is a very busy slide, but I wanted to include it for your reference about all of the factors that have been speculated to have contributed to the accelerating pace of EIDs around the world. So there can be microbial changes that occur, such as mutations in specific pathogens that led to increased spread, such as pandemic flu, for instance. And then there are a lot of human factors that have changed, including increased contact with wildlife and non-wildlife environments, globalization for sure, with a huge increase in air travel over the last few decades like never before, and new urban agglomerations in parts of the world that were previously much less urbanized, such as parts of Africa. So these human changes, along with climate and other environmental changes, have led to expansion of certain vectors, most notably certain mosquito species, along with other vectors, for instance, fruit bats, leading to the spread of Ebola in West Africa. And finally, whenever there's war or other large political and economic shifts, lack of infrastructure can lead to inadequate resources to contain the spread of EIDs. So the bottom line, I think, is that this is just a fluke. I don't think this is just a fluke in recent years. I think we can expect to continue to see new EIDs frequently in coming years. So I'm going to give to you two different case scenarios. In the first scenario, CDC releases an alert about a new virus causing severe respiratory illnesses, deaths, and hospital outbreaks in Europe and Asia. And the presumed mode of transmission is thought to be droplet plus or minus airborne. And interim recommendations are contact droplet and airborne precautions. In the second scenario, CDC releases an alert about a mosquito-borne virus causing fever, rash, and encephalitis. How do you respond to each of these scenarios? So in the first scenario, it's clear why we must respond as hospital epidemiologists. Clearly, whenever there's a risk of nosocomial transmission, that's well within our wheelhouse, and if we don't respond ahead of time, then we'll be the ones dealing with the mess after the fact. But what's been historically more controversial, I think, are scenarios like scenario number 2, where there isn't a clear risk of nosocomial transmission. So I think there's been a philosophical debate, is that the job of hospital epidemiologists to handle or not? And I know different hospital epidemiologists feel differently on this issue, including recently with the issue of Zika. So I think each institution must decide for itself what the role of the hospital epidemiologist is. But my personal experience, at least, has been that infection prevention and hospital epidemiologists are seen as hospital experts on creating policies, procedures, and processes related to infectious diseases. And in many institutions, leadership and other groups may not necessarily see the distinction between these two scenarios. But in any case, however you come down on scenario number 2, my point is that any infectious disease alert can lead to a crisis. So I'm going to make the argument that as a hospital epidemiologist, whether we like it or not, it's important to know how to effectively communicate in a crisis. Because during a crisis, people want credible information as soon as it becomes available, and hospital epidemiologists are usually the first to know about outbreaks, new cases, modes of transmission, and evolving science, and are seen often as the subject matter experts and trusted for information. They're also used to communicating clearly about protective behaviors and infection control procedures to patients, visitors, and employees. So I'm going to start by saying something that may seem intuitive, but I don't think we necessarily always take it into account when preparing communication during a crisis. And that's that communicating in a crisis is different because people absorb information differently during these situations. So people tend to simplify the messages that they hear. they often hold on to current beliefs that they have, and so they can be difficult to sway. They often look for additional information and opinions from multiple different sources, and they tend to believe the first message they hear. So the psychological impact of crises is something that we might underestimate at our peril. These include denial, fear, anxiety, confusion, dread, hopelessness or helplessness, and infrequently but occasionally even panic. And panic is really what we saw during Ebola in many instances. So that's why crisis and emergency risk communication, or CERC, is a different animal. I think many of us as hospital epidemiologists have learned to be effective communicators because that's such a key component of what we do. But the whole reason for this webinar is to make you think differently about communicating during a crisis. So CERC, or Crisis and Emergency Risk Communication, addresses psychological barriers and different communication challenges that occur in a crisis. It recognizes that during emergencies, we work under the most impossible time constraints and therefore may end up making mistakes, and we must accept the imperfect nature of our choices sometimes. And CERC also draws from lessons learned during public health emergencies, as well as research in the fields of public health and emergency risk communication. And if you think hospital epidemiologists have to know about crisis communication, think about what CDC has to do as a public health agency every day. So there's clearly a lot we can learn from their experiences. So these are CDC's 6 core principles of CERC. They may seem simple, but I can tell you that during a true crisis, they can be quite hard to follow. So they are: be first, be right, be credible, express empathy, promote action, and be respectful. So let me give you a little more context around each of these. So the first principle, fittingly, is be first. So remember that during a crisis, people tend to believe the first message they hear. So you have to get out there quickly if you want people to listen to you. And if you don't get information out first, then someone else will. And again, as I mentioned before, hospital epidemiologists are often seen as important spokespeople. So using Ebola as a case study, let me talk about being first. This is one of the things at my institution that we initially did pretty well, although I'll be honest and tell you that we haven't always been quite as prompt with all of our communication. But on Monday, July 28th in 2014, CDC released its first health advisory warning of increased risk for travel-related Ebola in the U.S. And this was in the setting of the first case of Ebola being imported to Nigeria, as well as Ebola having been diagnosed in 2 U.S. healthcare workers in a Liberian hospital. So CDC recommended to start screening all patients for travel and symptoms at this time, and they also released PPE recommendations for U.S. hospitals. So that Friday, we released our first Ebola clinical bulletin for our staff. And one could argue that Monday to Friday is already too long, but this is actually pretty fast for us. And our first clinical bulletin followed a certain template or format that we've developed over the years, starting with a situation update and epidemiology, clinical signs and symptoms, and then followed by recommendations for PPE and lab testing. And it also included sort of a canned phrase that we have used over the years for EIDs that says, please be aware that this is an evolving situation and we will continue to keep you updated. So it's helpful to have templates ready, and that doesn't mean you know ahead of time what content will go in there, because EIDs by definition are a new and evolving situation. But at least in terms of a general format, have some idea of how you might want to do this. And usually there's no need to reinvent the wheel either, because you can use the CDC or health department memos as a basis. So I gave you an example of what we did reasonably well by our standards during Ebola by getting the first clinical memo out quickly, but these are some of the pitfalls I've experienced around trying to be first. So first of all, perfect is the enemy of good. I think that infectious disease physicians and hospital epidemiologists may not be great at being first, because Often we tend to be very detail-oriented and even perfectionist. But remember that the first message doesn't need to have all the answers, and don't wait weeks to get something out. And then also remember to tell staff what the hospital is doing to prepare, not just what they need to do. So as hospital epidemiologists, we get very focused on telling people exactly what they have to do. But if you don't tell staff also what the hospital is doing on a larger scale, it's as if it didn't happen. So you may be doing so many different things to prepare, but the staff may think you've done nothing. Another pitfall to trying to be first is, especially for large institutions, there can be too many layers of review and approval. So you probably, for a true crisis, need to create expedited channels for reviews, approvals, and pushing messages out. And the third pitfall is, even if you try to be first, you can be undermined ultimately if there are mixed messages coming out from different groups. And this can occur if you don't align with key opinion leaders from the beginning, such as ED leadership or critical care leadership, whoever might be out there on the front lines who may be telling people something different from what you've said. So you may need to consider creating work groups to get all these people together and on the same page. So principle number 2 is to be right. And this can be hard in an EID because, as I mentioned, it's by definition evolving. So say what's known, what's not known, and what's being done to fill in the gaps. And that could be as easy as saying we're working closely with experts in the health department in trying to fill in the gaps. I will say from experience that it's much easier to express uncertainty or shades of gray verbally than in a written memo. So when it's that important, you probably have to supplement written communications with verbal. And later on in this talk, I'll mention different possible modes or avenues of communication. Principle number 3 is to be credible. So be honest and truthful, strive to be transparent and not overly paternalistic. This can be hard when you're trying to reassure people, but you have to admit that we don't necessarily know everything there is to know. And one of the pitfalls here is when you want people to remain calm and not panic. I, at least personally, have seen myself get a little too black and white. So going back to Ebola again, we said that healthcare workers in the U.S. were very unlikely to get Ebola, and this was based on pretty limited data. So it may be okay to say this, but maybe don't pound your fist and tell people it could never ever happen. So since that experience, I have to say I've tried to soften some of my messaging for people in areas of uncertainty, and I'm more likely to frame things as this is our current understanding based on the information we have. So I'm combining principles 4 and 6 here, but these are express empathy and be respectful. And obviously this is something we all want to do all the time, but feeling respect and empathy is really not the same as expressing it. And I'm going to share with you my personal cautionary tale here. When Ebola first hit, our original plan was that any suspected or confirmed Ebola patient would be admitted to one of our pre-existing medicine services that we have that's staffed by ID attendings and medicine house staff. So on Monday, October 13th, we had a meeting scheduled with house staff to reinforce that plan and do a Q&A. But the Sunday, the day before that, it was reported that the first U.S. transmission to a healthcare worker had occurred in a nurse in Texas. So on Monday, a last-minute decision was made to exclude all trainees from caring for any suspect or confirmed Ebola patients. But no plan had yet been created for who would admit the patient. So I had to show up at this meeting with only partial information. And obviously, I would not have scheduled that meeting ahead of time had I known that we were going to be in the middle of a major shift in the plan. But this was the medicine house staff that I work with closely and know really well. So rather than rescheduling the meeting, I showed up. And I was honest and transparent that the situation had changed and we were going to exclude trainees and we'll work on a plan. But people were angry and afraid, and they wanted to know, what if a patient comes in tonight? So the principles under express empathy and be respectful are don't dismiss people's fears, don't use humor in times of crisis, emphasize what you're doing, and that you're there to help and support the people and processes. So really humanize the preparedness response. So I didn't try to use humor, and I didn't dismiss people's fears, but I did underestimate their fears. And the other mistakes that I made, don't show up without first considering what people may ask. And for frontline people, often those questions are really immediate questions. What do we do right now? What if a patient comes in tonight? And I was unprepared because it was the medicine house staff. I thought of them as part of my team, part of my work family. But the key is that this was a crisis, so I shouldn't have shown up trying to communicate as if under normal circumstances. And as hospital epidemiologists, I think we often tend to be focused on really precise, detailed action plans, but we shouldn't forget that in crises, sometimes you just have to express empathy, and that can help even if you don't yet have a concrete plan. So after floundering a little bit, what ended up eventually working was just to say, we understand that people are afraid, and make a statement of commitment even if the details and logistics were entirely still unclear. So we ended up saying, we, the infectious disease and hospital epi team, will be here no matter what, and we will take care of the patient. And we didn't know exactly how we were going to do that, but it was true, and that's really what we needed to say at that point. So finally, the last principle is to promote action. And where you eventually have to get to, you can't just express empathy, is to create action plans and clear protocols for different groups and locations. And giving people direction and tasks in the setting of a crisis can help calm anxiety and help them regain a sense of control. This is something I think that the Nebraska Medicine Group did incredibly well as they were preparing to care for several Ebola patients. And the clarity and the level of detail of their protocols was very helpful. So I think this is something hospital epidemiologists are pretty good at, but in the heat of the moment, when you're doing this over hours and days instead of weeks to months under normal circumstances, it can be hard to remember all of the relevant parties. So it can be helpful to put some thought into who those groups are ahead of time. So this is just a potential list of groups for whom you can target action plans, and not all groups will be relevant under all circumstances. So there may be protocols that all staff must follow. For instance, if staff themselves are at risk of acquiring the emerging infectious disease in the community, then these are the symptoms to watch out for. You tell them and tell them this is what they need to do if they develop them. And then there may be specific protocols for medical staff, including subgroups of medical staff, nursing, respiratory therapy. It may be intuitive to think of some of these more clinical groups, but then there may be other less clinical groups that you don't immediately think of, but that definitely became relevant during Ebola. So environmental services, and what do you do about the contaminated environment of a possible Ebola patient? What about security staff, registration staff, lab transport, materials management, occupational health? And then there also can be location-specific protocols, such as what you do in the EDs versus what you do in ambulatory and what you do in an ICU. So if you don't think about all of these potential groups, you might forget in a crisis to include them in your planning. So that's just my brief introduction to the 6 core principles of CERC. But before I move on to the CERC life cycle, I do want to take a moment to put this all into perspective. So remember that all the advanced planning in the world can fall apart in light of a true crisis. So be flexible and be prepared to change things up on the fly if you need to. And be prepared for anger, criticism, and adversarial interactions during a crisis. But remember that people are upset and afraid, so try not to get defensive and be humble if possible. And remember that you will be affected by the crisis too, so you may not respond the way you normally would if you're tired and stressed out. The leader is spokesperson, so I think I've come back to this several times. You may think it's more important for you to get things done during a crisis than to communicate what you're doing, or that maybe others can do the communicating. But again, since hospital epidemiologists are often the leaders in these situations, you're probably also the most effective spokespeople. You may need to designate additional spokespeople, such as hospital leaders and so on, but doing the communication and effectively communicating is really a crucial component of EID preparedness. You might end up being wrong, as often happens in an evolving situation, and if so, you'll just have to be honest and be prepared for many what-if questions that really don't have real answers. So now that we've talked about the core principles of CERC, what is the CERC life cycle? Well, it's a way to think about the different stages of planning for a crisis. And I'm going to talk through some of the things you might want to think about during the early stages to be prepared to effectively communicate. So the pre-crisis stage starts basically now or any time. It's when you start to plan to address crises that may come up in the future. So you try to predict and address scenarios you might face at your institution. Think at least about different broad categories of EIDs and how you might start to plan. So for instance, how you would plan for a pandemic flu situation or a SARS type situation or another Ebola-like situation. Obviously, the extent to which you can do this depends on how much information you have, and you may have very little initially with new EIDs. But there are certain scenarios we know we might face at some point in the future, like pandemic flu. And at a minimum, you can start to put a framework or structure in place for your institution. So identify resources and mechanisms for communication. Recognize which groups you need to connect with as the crisis emerges. And as I alluded to earlier, it's really important to build relationships with key groups and opinion leaders to ensure unified communication later on. So for instance, the work groups we pulled together at the time of Ebola, such as the ED work group, an ambulatory work group, et cetera, turned out to be good groups to pull back together subsequently to address things like Zika testing, for instance. You can also start thinking about how to integrate your crisis communication plan into your overall preparedness and operational plan for your institution. So what is your emergency management structure? Do you have an incident command structure? What about your internal communications group? And as I mentioned before, you probably need an expedited process for approvals and dissemination of information during a crisis. So as much as you can start to plan during this pre-crisis stage, you'll be very happy you did it once the initial crisis hits. However, for many of us, before you know it, you may be in the initial crisis stage already. So I think the Ebola outbreak starting to emerge in West Africa was the initial stage of the Ebola crisis, and we know that in retrospect, but did we really recognize it quickly enough that it might hit us at home at the time? So an initial crisis is often heralded by a CDC or health department alert. Other examples include the measles outbreak in Disneyland, which was a trigger not just for local California hospitals, but for hospitals around the country and probably even around the world, given all the tourists who travel there. The MERS-CoV alert, Zika, et cetera. So some of the pitfalls here might be that there may be little to no time to prepare once it's recognized that an EID could be a threat to you locally. And I already mentioned some of these examples, including about measles and Zika and Ebola. There can also be different and escalating levels of crisis as an EID is perceived to be coming closer and closer to you. So after the CDC Ebola advisory in July, things perhaps didn't really hit home, literally as well as figuratively, until September when we had the first case of Ebola diagnosed in the U.S. And then things really escalated in October when we recognized that our healthcare workers or perhaps not as safe as we previously thought. And then for me personally in New York City, it was only a few weeks between that point and when the returning physician was diagnosed with Ebola in New York City and was admitted to Bellevue. So the crisis you may experience in different waves as it starts to move closer and closer to you. So when the initial crisis stage hits, that's when you need to quickly create and modify your messages. I already talked about engaging key stakeholders, and again, you really have to tailor your communication depending on the audience. And I alluded to this earlier when talking about action plans, but the same holds true even just for how you message and communicate. So you may have different ways of communicating to clinical versus non-clinical groups, hospital leadership versus frontline staff, different people in different areas. So all of these come into play. This is an expansion of the table I showed earlier about creating and tailoring action plans. But beyond action plans, you also have to communicate to other groups like hospital leadership, make sure whoever you report to, your boss, is kept up to date. And in a rapidly evolving situation, this probably means communicating on even a daily basis. And what about your emergency management and incident command structure? Do they know what's going on? Other groups like the health department, EMS, the medical examiner, all of these came into play during Ebola, and of course your patients. So the bottom line is that you can really never over-communicate during a crisis. And again, it's important to tailor what you message to your specific audience. So for staff, really focusing on the 5 W's, who, what, where, when, how. So what's going on, what do they need to do, what the hospital is doing to prepare. For hospital leadership, you probably also want to focus more on the big picture, again, what you're doing to prepare, and then any risks and vulnerabilities that you see in your plan, and potential issues that may come up from either patients or the media. For patients, again, tell them what the hospital is doing to prepare, what they can expect, and what they can do, if anything. And then for external partners, have a protocol to alert your local health department authority, know who to alert, when, how, have the right phone numbers, and you may also need a plan for intra-hospital or inter-hospital transfers through EMS or removal of remains with a medical examiner. And again, these all became relevant during Ebola. So again, So the University of Nebraska, again, I think had a very thorough internal communication plan with many different types of communication, including those listed here. So they had a letter to patients that was signed by their president and CEO. They had a Q&A for staff. They had a memo to staff about the preparedness plan. They had a talking points memo for leadership and a weekly update memo. So granted, they had maybe more time to prepare than many of us might if a patient just walks through our door because their patients were transferred to them in a planned way. But I think we can learn something from all of the planning that they did. So that brings me to different modes and avenues of communication. In a crisis, you will need to think about employing all of these potentially. So the hospital intranet and email memos, these are things we often end up relying on in large hospital systems like mine. But in a crisis, these are really probably not sufficient. So these, during Ebola, were supplemented by things like in-person meetings and huddles, FAQs and Q&As, town hall meetings. We did this really frequently during Ebola, and they were open to all staff. And I'll be honest, it wasn't one of the more fun parts of the job because, again, people are scared and angry. But it's worse if you don't give people a forum to feel heard and feel like their questions are being answered. I will say, however, if you're going to do this, don't put yourself out there without any support. We had our hospital leadership alongside us. Our COOs were there, and I think that was helpful. Social media, I think, depends on your institution's culture and policies on social media, but it may be more appropriate for communicating with external groups like patients or the media or the public. And just to give you an example, on the right-hand side of the screen, these are some of the communications we put out during Ebola and then subsequently posted on the Ebola site we created on our hospital intranet. So we had all kinds of protocols and screening tools depending on where the patient was located. We had updates for all staff. We had updates for physicians. We had Q&As and HR policies and updates as well. So the Q&As we did in person during town halls and smaller meetings, but we also had an email Q&A option. And these are some examples of the kinds of questions we got. I work in the cath lab. Should our staff screen? Should surgical masks be placed at the entrances of ambulatory sites? What about staff whose head or hair can't be accommodated by the current size of the face shield? How did the nurse in Texas end up getting Ebola, et cetera? And of course, the types of questions and the volume really varied over the course of the outbreak. And of course, most EIDs won't be at the level of Ebola, which really had its own unique blend of transmissibility, severe morbidity and mortality, and no cure or vaccine at the time. But I learned a lot from that experience, and if you prepare, if not at that level, then at a level just below that, then I think you can easily handle the relatively smaller crises that come your way. So before I start to wrap up and take questions, I wanted to point you to some additional resources that are available through CDC about crisis communication. Since I just did a fairly brief overview of CERC, the CDC-CERC website, which I'll share with you, has some really helpful checklists and tools. So for instance, this is a pre-event checklist that might be helpful for you to review with your communications group. Some of this you can see has to do more with external communications with the media, which you'll hear about during the second talk in this webinar series. But it also talks about things like expedited communications channels. So for instance here, it talks about a written procedure and agreement on clearance procedures and how quickly that can be done in the setting of an outbreak. And then this checklist continues, but it also talks about getting things posted quickly onto your intranet, also how to conduct town halls and training for people in communication and so on. And then this is one of the other resources that's available. It's a template for the first message you might send out in a crisis. So the way this is structured, it says it starts with an expression of empathy and then clarifying facts. And it clearly says make sure you fill in only the verified facts. Don't put it in if it's not clear. Mention what you don't know, the process to get answers, and a statement of commitment. And then there are some tips on the right-hand side that talk about some of the things to avoid. Avoid jargon, avoid humor, avoid extreme speculation. Say we, not I. So you may not choose to structure your first message during a crisis like this. You may have additional things in there. You may do it in a different order. But I think that this is a good thing to keep in mind. And you can also see that the first message doesn't have to be incredibly detailed. So, and then finally the last resource that I'll share with you, but again, just a drop in the bucket for all of the things available on the CDC website. This is a needs assessment for CERC, not just for EIDs, but in general, and it really kind of talks through, does your organization have a plan, and is it well integrated, and who are the designated spokespeople, and does it have all of the following elements in your plan, and so on. So I will say it can be overwhelming looking at these, but don't feel you need to have every last thing on these lists in place. They're just helpful guides, and I think that it helps frame how you should think about crisis communication. So again, this is just some really basic information on emergency communications, and the CERC website does have a lot more in terms of information and tools. And the CERC email address is also listed there if you have specific questions. So in summary, I tried to weave the CERC framework in with some personal lessons learned from my experience, and I hope that was helpful. My take-home messages are that you will be increasingly confronted with EIDs. The length of the pre-crisis phase of the CERC life cycle will vary, so advanced planning is key. It's important to integrate your crisis communication plan into your overall preparedness and operational plan. And once you transition from the pre-crisis phase to the initial phase, you'll need to act quickly. Remember to remain sensitive to your audience when developing crisis communications. You will need to use probably multiple different avenues of communication in order to be transparent. And all communications have to balance the factual and psychological needs of stakeholders. So I will stop there. Thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Faruya, for an excellent and very useful overview of how hospital epidemiologists can effectively communicate during a crisis. This is Judy Guzman. I'm the advisory panel chair for the SHEA CDC ORTP training program. I wanted to mention to all the participants that the slides from today's presentation will be sent out to participants following the webinar today, and the webinar is also being recorded. We do have some time for questions, and for any of the webinar participants that have any, you can send them, you can type them in through the chat box on your screen, and they'll be triaged appropriately there by the chair of the webinar. And we do have some time for discussion as well. So Dr. Faruya, I'm going to go ahead and read those submitted questions to you. Does that sound good?
Sure, go ahead.
Okay, great. One question from a webinar participant asked, in a time of a crisis, should everything that is communicated, even at the hospital level, come from the Department of Health in these situations, and how do you coordinate that?
So I think that obviously whatever communication you are putting out to your institution needs to be aligned with what the health department puts out, but there is going to be some tailoring and individualization of the planning that you'll need to do. So I think that whatever the health department puts out, usually there are some more details where their recommendations will also need to be adjusted for whatever your own operations and issues are. Hope that answered the question.
Okay, great. And a couple participants have asked if you could just one more time clarify what the CERC acronym stands for, and maybe if you can show that slide again, that would be helpful while we have this discussion.
Yes, so CERC stands for Crisis and Emergency Risk Communication, and I just went back to the slide where we're showing the website as well as the CERC email for any questions.
Perfect, thanks. Another question from another participant. How do you handle it if your staff members at your hospital just don't seem ready to accept the situation because of poor baseline knowledge regarding the situation or the infectious disease, or a poor understanding of transmission-based precautions? How do you handle that?
Yeah, that's a great question, and I think a really tough one. I think that actually sometimes a crisis is a good opportunity to really impress upon people the importance of transmission-based precautions and how to protect themselves and others appropriately. So in my experience, sometimes those are the times when you can actually start to reach people. It can be difficult ahead of time because different groups have different levels of engagement, but sometimes it's also a matter of during Ebola, for instance, I and our other hospital epidemiologists really had to go kind of from group to group and meet even with frontline staff to talk through some of these issues.
Okay, great. And then kind of along the same lines, another webinar participant asked, how do you address possible failures, say in effective use or correct use of PPE, without putting your staff on the spot when you're doing education to your staff as a whole? For example, the nurse at Texas Presbyterian in Dallas who may have potentially had a breach in the PPE protocol as a risk factor for transmission. How do you address those kind of more delicate details?
Yeah, I think certainly we try to avoid pointing fingers or assigning blame to anyone. And I think that the nurse in Texas, it was kind of a delicate situation because, and I think that ultimately what people thought was that that was a situation that really probably could have occurred in most of our institutions, given the fact that there wasn't the level of preparedness nationally at that time. So I think that that was the overall messaging, that the situation was evolving, we were learning more, and trying to really prepare people on an institutional level and on a national level more so than we had been before. And I think that on a day-to-day basis, trying to get people to improve their compliance with PPE. Sometimes some of the things that can help, I don't know if the question was getting at this, can be if you demonstrate kind of right and wrong ways of putting on PPE, really as more of a demo kind of thing rather than trying to point people to their own mistakes.
Thanks. That sounds like a great way to handle that. Another participant asked, and was there differences in communication tactics between non-tertiary care and tertiary care facilities? I don't know what the different types of facilities there are in your healthcare system, but could you speak to that at all in terms of any experience you had? Was there any difference in how to approach communication?
Yeah, I mean, I think, again, we had many different levels of communication, so there were things that probably all staff needed to know. While we anticipated that there was more likelihood that certain areas might encounter a patient with suspected Ebola, such as the EDs or maybe infectious disease clinics or primary care clinics and so on, maybe more so than a cath lab, somebody coming in for an elective procedure, for instance. Given the heightened level of concern, I think we did have a basic level of communication where we really felt that all staff had to be prepared for even a very unlikely event of somebody walking in the door who might have had the travel and the symptoms. So I think that there was this basic universal level of communication that was supplemented for the areas that we thought were really more likely to encounter those patients.
Perfect. Here's a great question from one of the participants. Did you have any situations in your preparations or in your planning with Ebola or with any other pathogen when you had to deal with additional parties that may have an interest in an emerging infectious disease but are requesting steps that may not be in alignment with the CDC or SHEA or Department of Public Health? The example that they give, that this participant gives is the differences with Ebola and the California. In California, they had a regulatory body that was recommending waste management. The recommendation of waste management, like the flushing things down the toilet with bleach and other things, differed than what public health and what the hospitals were saying. Did you have any situations like that where you felt like you had to kind of choose for your own institution what seemed to make the best sense, and how did you handle that?
Yeah, I think that's a great question, and I don't think I necessarily have a good answer for how to address that. I think that's one of the reasons why Ebola was so hard. It was so rapidly evolving, and there were conflicting recommendations out there from various groups, and some people going on the very aggressive side and some people on the very conservative side. And we saw that, I think, even within our group of SHEA members and hospital epidemiologists, and nobody really knew the right answer. And so I think that's one of the reasons why Ebola was so hard. So we did encounter that. For instance, the groups that were likely to be transferring or transporting patients to our institution were the New York Fire Department group and the EMS group that worked with them, and so they had their own protocols for all kinds of PPE that we were not recommending for ED staff. And that was something that we really had to take on a case-by-case situation, really talk it through with each group. And the messaging, I think, was that this is what we think is safe and adequate, and then there may be people going above and beyond for a variety of different reasons. But I can't say that I have a good answer or a good solution for how to address that. It does take a lot of discussion and addressing on a case-by-case situation.
Yeah, absolutely. I think a couple webinar participants have mentioned that already in the questions and in the chat, where all of us hospital epidemiologists were recommending PPE for our staff and that they didn't need to wear yellow hazmat suits. But then when they watched nightly news and saw patients getting transported, the transport EMS staff were wearing hazmat suits. So I think
absolutely. I think it was very difficult, and I think that we tried to also explain to people why there were also shortages and who was able to get what. There were so many different variables that played into this, but I think that we did try to explain to people that no matter what you use, you have to have the right equipment, and you have to be well trained in how to use it, and that the training piece we really tried to focus on was the key. It's not just a matter of what you're wearing.
Absolutely. One participant is asking, how do you balance between ethical expectations or ethical concerns from the staff and emergency intervention using CERC, using the kind of CERC structure?
I am not sure I understand that question fully. Perhaps that participant can clarify further. Judy, do you have a better sense of?
No, I don't. And I'll check and see if there's any follow-up there. Okay. And in the meantime, while I'm scrolling through these, there's another question. Actually, a couple participants have asked, did you have any experience with trying to coordinate communication or assisting in improving communication with patients that are in extended care facilities, long-term care facilities, those type of facilities, not acute care hospitals that may have been in your community or affiliated with your healthcare system?
So we don't have long-term care facilities within our system directly, although some of our sites do receive a large proportion of patients from those types of facilities. We did not end up doing a lot of work with transferring facilities. I think that we were mostly focused on the transporting groups such as EMS and FDNY, as well as our protocols for transport, but we did not do any direct communication with those facilities.
Okay, great. And now it's 2017, and one of the participants is asking, in pre-scheduled diagnostic centers, in your emergency department, in your clinics, do you still or do you currently have any screening questions regarding patients who may be presenting with transmissible or infectious diseases?
So we do not. We are in New York State, we are still under a health commissioner order that requires screening for those kinds of things for specific areas. So the way that the commissioner order is worded is that you should screen for travel and symptoms in patients who are presenting to areas likely to have communicable diseases. So we really took that to mean primary care clinics, infectious disease clinics. So we, from an ambulatory perspective, we narrowed it down quite significantly. So we certainly don't, at this point, have other areas, psychiatry, ophthalmology, elective procedure areas do that kind of screening at this point. And I would say it's certainly not warranted, I don't think, given the current level of Ebola in Africa.
Okay,
I will
great.
say, however, I think that for patients who are showing up with infectious type symptoms, it's always good to ask general travel questions, not specifically related to Ebola. But I think that's outside the scope of that question.
And I think this question, I think all of us as hospital epidemiologists are always trying to find the best way to do this. There's been several webinar participants that are asking, how do you keep the momentum going? It seems that staff have forgotten about the importance of good hand hygiene, donning and doffing effectively, not just for Ebola but for other pathogens. And how do we keep staff engaged and remembering that it's just a matter of time before the next emerging pathogen comes?
That's an excellent question, and I wish I had a good answer for that too. I think that it's true. People are overwhelmed. There are so many things kind of competing for their attention, and so when the immediacy of a crisis goes away, it can be hard to sustain any kind of momentum that you previously had. I think that some of the things that we've done have been to try to remind people, and usually there's been something on the horizon more recently, even if it's not Ebola, then maybe MERS-CoV. If you're in an institution like we are with lots of international patients returning travelers and so on, we try to kind of remind people that that Ebola may have subsided to some degree, but there's always something on the horizon. We try to remind them about more recent EIDs, and then also just bring it back to some of the more common non-emerging infectious diseases like flu or other things that staff need to remember to protect themselves from. Sometimes some of the motivators are not just around infection prevention, but they're around more mundane things like regulatory requirements, and reminding people that if you're on schedule for a regulatory CMS Joint Commission survey, then these are some of the things that they're focusing on. So I think you have to be creative and try to use whatever you think might reach people. But I agree that it's really a challenge.
It's a continuing challenge.
Yeah.
A few participants have asked about any existing guidelines or documents in terms of managing outbreaks, and I want to mention one more time for those who weren't on the webinar at the very beginning during my introduction, the SHEA CDC Outbreak Response Training Program. Today is really the kickoff of this 2-year program, and there's going to be a lot of great training tools and opportunities that are going to be coming out over the next 2 years, including our ORTP expert guidance panel is writing an evidence-based preparedness and response document. So it will look like a guidance document for hospital epidemiologists for general guidance in managing an outbreak and also touching on specific pathogens as well. So I wanted to make sure I mentioned that because there's been a few questions.
Yeah, and Judy, sorry, Judy. I also wanted to put in a plug for all of the resources that will be coming out through the ORTP. I think in my experience working with this group, it's easy to get lost in the thousands of documents that are out there around managing EIDs, various different types of EIDs written for different groups. But I think ORTP has really done a great job of starting to wade through that morass of guidance out there and putting it into perspective for hospital epidemiologists.
Yeah, absolutely. Yoko and I both serve on the advisory panel, and we actually, our panel had a very busy summer where we reviewed many references that were recommended by the CDC, and our panel worked to really help to sift through all of them and choose which ones we thought would be the best, kind of the benchmark documents for reference documents for the ORTP content. And so just like Yoko said, there's a lot more coming. All right, here's another question from a participant. Do you have any advice for communicating effectively with potentially resistant administration members, the C-suite, or supervisors or management who don't agree with the suggestions that you have in outbreak management?
That's another great question. I would say it's probably pretty crucial to have a partner and an ally in the C-suite. I think that if you don't have anyone at the top level of your institution that thinks that this is important and needs to that the institution needs to make it a priority, then I think you have a really uphill battle on your hands. So I think our infection prevention and control group reports to our chief quality officer. I know that different groups have different reporting structures, but you really probably need to work on creating an ally in that group. I think that once you have that top-level support, then it's going to be easier to then address people at a somewhat lower level, a supervisor, a director, or somebody who is more resistant. But I think it's very hard to do if you don't have somebody at the higher level.
Right, and I think it's important to mention that we should maintain or create those good relationships before the crisis.
Yeah, that's a good point, and I think sometimes it's also a matter of mustering your troops. So if you're getting resistance, then trying to create partnerships with other people who might be similarly motivated to address the EID. So maybe there are people in the ED leadership or somebody that you can try to kind of get on your side, and then as a group try to address people who are more resistant.
Okay, great. For those of you who joined the webinar a little late, somebody did ask what does ORTP stand for. So I just wanted to mention again in this past summer the CDC contracted with SHEA to create a new training program, and the training program is called the SHEA CDC Outbreak Response Training Program, or ORTP. And the goal of this program over the next 2 years is to train hospital epidemiologists to effectively respond to infectious disease outbreaks and public health emergencies. And so this today's webinar is really the kickoff of the ORTP, and there'll be a lot of other training opportunities over the next couple of years. Let me see here. Here's a question, and you did touch on this a bit already in your webinar, but one participant is asking, how soon should we, quote unquote, be first in putting up an alert? Trying to make it look like we're not lagging behind with getting the information out to staff and to the community. But but also looking like a leader and being up front and having a good plan?
Yeah, I think it's hard to put an exact time frame, for instance, a number of days or something. In general, I think that it really depends on the type of information that you need to get out there. Most of the time, I think that if it's something urgent and requires a significant change in practice for staff, such as you have to start screening all patients for travel and symptoms, that's something that you probably need to get out in a matter of days rather than in a matter of weeks. There may be things that are really, really urgent that you have to try to turn around within a day or two. But I will say that most of the time we're working on a time frame of several days. I think that sometimes I feel like we get bogged down and it takes time for everyone to review the materials, and it ends up being weeks as opposed to days. But I think it really depends on the urgency of the information that you're trying to get out there.
Okay, great. One participant asked, do you have any experience in managing a crisis and having insufficient PPE supply? And if so, or if you know of any colleagues that had a PPE supply issue, how did they handle that with communication?
So I think that the only time I've personally experienced that was during Ebola, and I think probably many people experienced it during Ebola. And so we had to work very closely with our materials management group, look at multiple different alternatives out there, and do the best that we could with very limited supply. I have not personally experienced real PPE shortages when outside of the Ebola situation. I know that sometimes issues can come up when it comes to enough masks for N95 masks or flu masks or something like that. But I think we have enough of a significant supply chain, so we're fortunate that way. And every now and then we've had to work with our materials management group to come up with alternatives, but usually there are alternatives that are close enough. It's not ideal by any means.
Okay, great. And looks like we just have a couple more questions. One question from a participant is asking, now that we're this far out of Ebola, but everybody's still trying to expand their preparedness for any emerging infectious pathogen, how often do you recommend that your staff do outbreak drills? What are you doing at your institution?
So at our institution at this point, I think that drills are really at a quarterly frequency. I will say from my personal experience, it's pretty hard to keep people at a level that I think is really adequately prepared all the time. And I think that where I've gotten to over time in seeing this is that you may be doing drills at a quarterly basis, but then you'll probably, when it looks like an EID is going to hit, when you're starting to get into an initial crisis stage, then you're going to have to quickly ramp up and do basically kind of just-in-time training to supplement what you've been doing on a more, ongoing basis.
Okay, great. And this may be the final question here. What is the best way to educate and alert communities and the general public and that is kind of tuning into the response at your hospital, and also keeping in mind not affecting patient confidentiality?
So I think that that's the kind of situation where I would be working very closely with the hospital's communications group, in this case the external communications group, to make sure that whatever I think is the right thing is aligned with their overall kind of communication strategy. Sometimes what happens is that the communications group will try to will reach out to get our help to put out statements to the media about certain situations. We often when this happens, it's in light of information already being out there, whether it's from a patient or from the local health department or something like that, and then we have to respond. I will say that historically, I don't think that we usually kind of break the news about a patient at our institution and are the first ones to do that. It's usually more that that information is already out there, and we're working with the communications group to handle any kind of media inquiries or putting statements out. Sometimes we also, put signs outside of a hospital entrance, kind of depending on what it is. But we did, for instance, there was a local measles outbreak in our neighborhood a number of years ago, and so we worked with our communications group on putting out information based on that.
So we have a couple more questions that have come in. One is from a participant who's calling in from Ghana. And his comment is, during the Ebola crisis, I realized that PPE was retaining heat, especially in West Africa, and caregivers were sweating. The sweat was entering their eyes, and the caregivers were not comfortable. And those who cleaned themselves probably, had a high risk of getting themselves exposed or infected. And so the question is, when you did you have situations where you had a PPE ensemble plan, but during either training or providing care, you had to make changes in your PPE components? And how do you effectively communicate that to the right stakeholders so that prompt replacement happens for the safety of the employees?
Yeah, I think Ebola was a little bit different than, well, it was quite different than any other crisis or EID that I've dealt with. That was a situation where we were having really daily, multiple times daily communications with many different groups as we were working on putting the plan together. We did temporarily have a biocontainment unit that we had put together. And so we were in constant communication with probably really representation from all of the key stakeholders. I think that in terms of both comfort and safety, those were considered very high priority issues. So I don't recall having any pushback when we had to look at various different types of PPE and deal with what's available and not on shortage and we could get our hands on, and also what made sense from a safety and comfort perspective. We did go through a few different iterations to get to where we needed to get to. And then I think that the other issue that arose was also just a matter not just of the PPE, but also making sure that there was a plan in place so that people who were wearing the PPE would be relieved quickly and that somebody wouldn't be staying in the PPE for many hours at a time. So that was all part of our plan, and because we had so much constant ongoing communication during that time, we really didn't run into issues with changing the plan and getting that communicated out.
Absolutely. There's been a few questions and comments about how your epidemiology team collaborates and works together with your communication team. During the Ebola crisis, how frequently were you as the hospital epidemiologist meeting with your communications department or your communications lead? Was it daily or even more than that?
Yeah, I think, and I'm trying to remember back, and the Ebola crisis had different phases. So I think at the most urgent, we were having more than daily calls with a large group of individuals, including somebody from communications. And so, but again, that was somewhat unique. I would say that in a more typical EID type situation. It's more of an as-needed basis. But yes, with Ebola, things were changing constantly, and so whatever group conversations we had with representation from operations and nursing and materials management and EVS and in our group, communications had to be on that call, and that was, I think, crucial.
Okay, great. Here's an interesting question. How and what to communicate to other community hospitals within your state or your community that are considered "quote unquote" competition to your institution on a usual time period? Did you have to did you work to align your messaging with other hospitals or healthcare systems within New York, or did you feel like you were kind of in charge of really just coming up with a communication plan for your hospital and healthcare system alone?
That's a great question. I think that coordination is probably a good thing in these situations, but in the heat of the moment, I don't think that we really had the bandwidth to do much communication other than, if there was any specific questions that we might have had, more than just our own system. So, we have 6 hospitals within the New York Presbyterian Hospital group, and then we also have sort of systems types hospitals and regional hospitals, and so our communication was really primarily through that group. But I think that most of the coordinating was done through, when there was coordinating occurring at the city level or at the regional level, that was done through the health department, as well as through organizations, hospital organizations like Greater New York Hospital Association and so on. But we did not really initiate any of that at the time.
Okay, great. And there's one question about immunization, which I think it goes more towards influenza, and if we think back to the pandemic of 2009. Do you have a plan, or how do you allay fears or anger when a vaccine doesn't cover the disease of the outbreak, and staff feel that they're kind of losing faith in what we always try to educate and tell them to do in terms of annual immunizations or keeping their immunizations up to date? Have you had a situation where you've had to deal with that with hospital employees or staff?
Yeah, certainly, and I think that that's yet another challenge that we often face. I think that that we're starting to see more and more patients get sick with flu even after they receive the flu vaccine, because our vaccination coverage is so high now, thanks to a New York State order that if healthcare workers are not vaccinated, then they need to wear a mask during flu season. So we've been successful in getting our vaccination rates above 90% in the setting of that. And so therefore, we are seeing many more individuals who get the flu despite having received the vaccine. And I think it's a matter of trying to message to people that that the vaccination has some efficacy, so even if it's not 100%, or even if it's not even 80 or 90%, that it's better than no protection, and that even if you get sick, that of course usually you're going to be the symptoms and the severity of the illness may be less when you get the vaccine, but certainly I think that we're starting to see more and more of that with things like mumps vaccination or other things, but it is a challenge, and I think you just have to try to get people to understand that the vaccines still do something, even if it's not as much as we want it to.
Okay, great. I'm scrolling through the questions, and those that are remaining have either already been addressed or will be addressed on a future webinar. So I wanted to take the moment to once again thank Dr. Correa for an excellent and great overview of how hospital epidemiologists can effectively communicate during a crisis. I also want to put a plug in for the next ORTP webinar, which will be on May 23rd. And that webinar will be called Conflict Management in Times of Competing Resources and Priorities. So, and that will be given by Dr. Stephen Weber. who's the CMO and Vice President for Clinical Effectiveness at University of Chicago. Again, if you did type in a question and you may have missed the same question earlier in our Q&A session, the slides will be sent out, and it was also recorded, so you'll be able to review the webinar at a later date. And with that, again, Yoko, thank you so much for a great kickoff to the ORTP, and thank you to everybody who called in today.